In some cases, the patient might not even have the transportation to be able to go the 50 miles, or depending on who they are, they may not trust the hospital or the healthcare system. We certainly have a lack of trust in the healthcare system among certain communities of color, and particularly the Black population.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite, and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
On today's episode, Garry, Hayes, and I are going to be talking with Karen Conway, VP of Healthcare Value at GHX, about health equity. And Garry, we're going to be talking about health equity, and maybe people out there have an idea of what that might mean. Maybe they feel like they're involved in some aspect, or they see health inequity out there. But we're going to be really diving into why this is finally the time that we all need to get behind it, because there's economic drivers. But why should supply chain be involved, Garry?
Yeah, I'm curious to see how Karen will link that together. She comes with an amazing reputation, is well known in the supply chain world and speaking engagements. I think it's just a real blessing to have her on today. I'm really curious to see how she links health equity into supply chain, and just really looking forward to today's conversation. So, Karen Conway, here we go.
Here we go. Everybody stay with us.
I'm Hayes Walder.
This is Gary Skinner.
And I'm Justin Poulin.
A production of 17 Studios. You're listening to Power Supply.
Today we have the pleasure of speaking with Karen Conway, VP of Healthcare Value at GHX. And Karen, we have a very interesting topic we're going to be talking about today, which is health equity. And we're going to put it all into the context of healthcare supply chain. So I just want to thank you so much. You and I met, little story here, over 11 years ago, maybe 12 years ago. You were at the statewide AHRMM conference in Penn State. I had just recently moved to Pennsylvania and gotten very involved with the local AHRMM chapter. And you were presenting on the topic of UDI and talking about all the various potential implications for it. Obviously, a lot has happened with UDI since I met you, but I was in the small world of sterile processing, and we talked about how that could really improve information exchange on how to reprocess reusable medical devices. We wound up doing an article together at HPN. So honestly, I'm ashamed that it's taken me this long to get you onto the podcast.
It's a thrill to be here. And, I was looking for an email that you had sent related to this discussion, and having to admit that I apparently don't clean up my inbox very well, because I found an email from you right after that 2012 statewide conference, AHRMM conference at State College. So
that is right. Hilarious.
And I'll just say, UDI has a health equity connection, but we can get into that if you want to.
All right, you've got an email of Justin's from 13 years ago, and I don't keep them 13 minutes. I'm highly impressed. That's pretty interesting. But all right, Karen, I've known you, everybody knows you in this industry. But what keeps you busy right now? I know you've got some new news probably to share, right? What's been happening personally, maybe?
Absolutely. I guess I'm having my own supply chain. I am a week and 4 days ago became a grandmother for the first time.
How's that going? Is everybody healthy and happy?
It is absolutely amazing. I will tell you, I had 2 daughters, so I had, I carried them, I delivered them. It was a normal thing. But when my daughter got pregnant and I watched her through this whole process, I'm like, it's the miracle of life. It's amazing.
It's a blur when you're doing it. When you get to sit from the outside and watch it, it's pretty surprising.
It is just, and with so many challenges that we have in healthcare today, obviously, people go to the hospital when they're sick. It can be just a very difficult time. And then certainly in hospitals, we're having a lot of challenges right now. But then there are these parts of the hospital where just beautiful things happen.
Karen, I heard someone years ago say this. There's three reasons we go to hospitals, and all are very emotional. One's to be born.
Yes.
Second's to go back and be repaired.
Yes.
And the third is to go to die.
Right.
All three are highly, highly emotional places that people, if you're in them every day, you don't really think much about it. But as you as a new grandma walking into that labor and delivery room and seeing that, it's incredibly emotional. I remember as a dad but it plays a role in what we all do here.
So thank you. Thank you for that.
So you said that health equity, there's actually a play there even with UDI, which you spent a good part of the last decade plus, focused on that topic. But when we say, I think a lot of people already know UDI. That's an acronym, unique device identification. You almost don't even have to define anymore. It's become so commonplace, at least in healthcare supply chain. But health equity, I think people could make a lot of assumptions about what that means. But for the purposes of this conversation, can you define health equity and all the various forms that it can take and what it means to you?
Well, I don't know if I can get to all the various forms, but I certainly can. Health equity is really, I guess it's easier to describe it as the lack of health disparities or health inequities. And, it really is about making sure that everyone, regardless of who they are, where they live, what their background is, what their income level is, their education level, their race, their ethnicity, that they all have access to what they need to be healthy. So, and so it's not equal care because not everybody needs the same thing. But it's about access to, what you need, Justin, versus what I need. And what is it? And that's both clinical as well as social.
Can I ask you, maybe you could tell me if this is an example of health inequity. One of the things, we have several podcasts that we do on the network. One of them is focused on sterile processing, which is kind of how you and I connected originally, as I was in that area. And our chief medical officer for that brand, Beyond Clean, has said oftentimes to me that healthcare organizations, have an obligation to serve their communities. And in some cases, they're employing people below the poverty line, which has statistically shown to be a big indicator on whether or not they're going to have chronic illnesses or have more expensive care. And that it really kind of puts healthcare organizations in this weird balance or conundrum because, in some ways they're trying to stay fiscally viable. And in other ways, they may unintentionally be contributing, to poor health outcomes or futures, just based on the demographic of being from low income. Is that an example of health inequity or is that something completely different?
No, that's absolutely an example because there are many, which is the reason. And I'd love to get into some of those, but why I didn't give you the myriad list of them. But it's interesting, as you have seen, what's happening with health equity is many, many healthcare executives are now saying it's not just a clinical or a social, a moral issue. It's absolutely a economic, a business imperative. And that really ties back to value-based healthcare. But you have seen organizations really start to focus on diversity, equity, and inclusion. And many times they're starting with, whether it's a hospital or whether it's any kind of business, they're starting with, how can we ensure that we have diversity within our workforce, and particularly in hospitals, diversity in a workforce that is reflective of the community of the patients that they're serving. But they're also, you have to start inside with your own organization. And are you being equitable? And are you enhancing and respecting the diversity of thought, the diversity of people that are in your organizations? And we have found, as people have looked at how do we take care of the most underserved, the most disadvantaged individuals within, the patient population, but it's also, they're starting to look exactly at their workforce and making sure that they're taken care of. A good example would be, when there's a hurricane or a flood. I know this, in talking to people from Franciscan Missionaries of Our Lady Health System in Louisiana. When they had some tremendous floods, one of the things they were doing is they were taking care of their own people and giving them a place where they could come, make sure that they had clothing, had food, had shelter, etc.
Karen, this is a new topic for me, health equity. And I have a question, and I just want you maybe just to reference it. I think about the time to get care. Everybody gets the opportunity to get what they need from birth to, Hayes Point 3 times you come into the hospital. And so the length of time to see a specialist for someone that needs care, how is that coming into play? Like, you find all these places or mergers, acquisitions are shutting down, and you're having to travel further and further and further to go find a specialist, and then they're out 6 months and 9 months. Is that health inequity, as Justin was bringing up before? How do we get the time frame built into that model? I think about that a lot.
Gary, it is an example, but I think a bigger one is more whether or not they even have access to those specialists. So in some cases, some of the studies have shown that, based on your sex or based on your ethnicity, you are more or less likely to be referred to a specialist or to be referred for that kind of care. Now, you did mention with, closing, and this is particularly an issue in rural hospitals. 1/3 of rural hospitals right now are at risk of closing. And we saw a number close during the pandemic, and you'd have issues where, you've got people in a particular community who were very comfortable with the hospital. And then, in fact, I think there was an article, it was either in the New York Times or the Wall Street Journal about this with a hospital in rural Georgia. And in some cases, the patient might not even have the transportation to be able to go the 50 miles, or depending on who they are, they may not trust the hospital or the healthcare system. We certainly have a lack of trust in the healthcare system among certain communities of color, and particularly the Black population.
Your point about so many community hospitals closing is so relevant. And, it's obviously probably most of us, well, Gary lives in Idaho, so that whole place is rural, but most of us live within fairly close of healthcare. But if you're only acute care hospital that was 15 minutes down the road closes, we're not talking about specialists or any of that stuff, but just having some place to go and it's not there anymore, that's got to be scary. Even if you do have a car or you do have transportation, but just not having somebody 10, 20, 15 minutes down the road, that's got to be scary for a lot of people. And then unfortunately, it's a really relevant thing now because so many of the hospitals have closed and or even reduced their footprint.
Yeah. And that it is a problem too, because one, and I didn't realize this until just recently, that rural hospitals, oftentimes from commercial payers are reimbursed at a lower rate. And the other issue is, think about them keeping an ER open. They've got a much smaller population, and it's like, that's a very expensive area of care to deliver. So there's a lot of talk now about, how even within a large healthcare system, which has multiple hospitals, and they might even be in more rural or suburban areas, are talking about not necessarily every single hospital having every single service line, that we need to move the people around. So this is where it starts to get exciting, and it has an impact on the supply chain, is where are we delivering that care? moving it out of the hospital into the community, whether that's an ambulatory surgery center or into a patient's home. What's very interesting is watching some of the technology advances, whether it's remote patient monitoring and the ability to do diagnostics from somebody's home, or even robotic surgery. They do this in the military now, where literally a surgeon is using a robot and guiding a surgery 1,000 miles away. So
we had a very similar conversation recently just about how this is transforming the model and, who has access to the patient's information, like who owns it and how do we share that information? And then it's almost like I've seen a lot of manufacturers develop centers of excellence. And I feel like that's kind of what we're talking about, right? Is specializing in healthcare, but then because of the ability to deliver healthcare remotely, that you can almost specialize at a whole new level.
Absolutely. Absolutely. And I think it is a matter of, and it's really about this bigger, I think, puzzle we have to solve, which is not only, so let's get back to health equity and what works, what a particular patient needs. It's going to differ based on the patient because even though, we're all human beings, we all have different genetics, our anatomy, we may have the same body parts, but they're a little bit different. And so things work a little bit different. I think there's some tremendous opportunities in figuring out who needs what is going to keep them as healthy as possible, and where should we be delivering it, and how can we utilize technology to do that. But I'd really like to get back, if you don't mind, to something you brought up at the very beginning, Justin, and that's chronic disease. We spend so much time, quite frankly, in supply chain focused on the high dollar devices. And certainly we spend a lot of time, in terms of, how do you negotiate and get the best price, et cetera? How do you make sure that this is the best device for the price, et cetera? But the thing that's really impacting healthcare is the incidence of chronic disease. 60% of Americans have at least one chronic disease. 40% have more than one. That makes you a higher risk and a higher cost patient to take care of, regardless of what you need, why you would go to a hospital.
So I used to work, ironically, as a chronic illness care manager. And then after I left that program, I ran a wellness program. Both of those were my last clinical nursing jobs, and they were entirely focused on reducing or better managing chronic illness, because with the wellness program, it was for a third-party benefits administrator. So they had a lot of self-insured businesses that were going under because of the healthcare costs that were rising, and the population was getting older, and the costs of those chronic illnesses were climbing regularly. And then the chronic illness care manager was actually with what's now become Maine Health, and they were looking towards socialized medicine in the state in general. And some of the purposes of the program was to reach those patients who can't say non-compliant anymore, but to help them manage, their illness is very interesting. And what you're talking about is truly where I think the opportunity is. So how do we tie that back to supply chain? If we're talking about delivering care in a proactive manner and better managing the patient so that just the general costs of care that are driving premiums up and flooding hospitals with more acute management of disease, how does supply chain get involved in that?
Sure, absolutely. So I think a friend, I think of all of ours, Vance Moore, who worked at Mercy in St. Louis, he used to talk about how all change intersects the wallet. And so when I talk about health equity, I also talk about environmental sustainability, because the two of them intersect, I believe, at chronic disease. And it's really about the economics of healthcare, because every single society has a finite amount of resources to keep people healthy. And if you just think about things like 86% or more of our national healthcare expenditures are on chronic disease. Deloitte recently published a report, said that right now we spend an extra $300 billion on healthcare expenditures because of health inequities. And that's expected to reach $1 trillion by 2040. So those are just, and it's 60% of the reason that Medicare spending is going up. And as we know, it's going to be insolvent, the Medicare Hospital Trust Fund, by 2028, which means hospitals will get lower reimbursement. Okay, so I just wanted to get some of the economics there because I think they're pretty significant and why I believe we will finally start to see change. And this is where I can talk to you a little bit about what can supply chain do. So
that was some really good stuff right there, by the way.
It's good numbers.
It's really scary. It's really quite scary. But, I'll just digress for a minute because I was on a call the other day with a friend of mine. We were working on what's the 10-year vision. What's healthcare delivery going to look like in 10 years? Now, I realize, it's hard to say, but they said to me, Karen, why do you think these things are going to change? Because we've been talking about them for 20, 30 years.
Right.
And I said, because we've been talking about healthcare costs being unsustainable. But you know what? We're hitting that point of absolute unsustainability, and we have to do something. But there's some really interesting things happening in supply chain. So you mentioned, Garry, I think it was you, was talking about the role of the hospital in the community. You may have heard this term, the anchor institution. It is oftentimes, maybe if you have a university, it's another anchor institution, but oftentimes the hospital or the healthcare system is the largest employer in that community. And if you think about health inequity or why are certain populations sicker than other populations, it has to do with the fact that, it has to do with, do you have a job? Do you have a job that pays a meaningful, a livable wage? Do you have a house? Do you have a house in a safe neighborhood? Do you have a car that can get you to the doctor? Do you have access to good food? I'll digress for a minute and think about that tragic shooting at the grocery store in Buffalo, New York. The real tragedy was, certainly the tragedy that people died, but there were people there. It was the only grocery store in the neighborhood. And there were people who died who had brought people to that grocery store because they didn't have a car, etc. So it's access to good food. So a perfect example would be the Geisinger Fresh Food Pharmacy, where, so if I can take a little bit of time and tell the story. So I was talking to Andrea Feinberg, who was running the program at the time. She's actually the wife of David Feinberg, who is the CEO of Cerner. But David was the CEO of Geisinger at the time. And she had started this fresh food pharmacy because they had recognized that they had an even higher level of type 2 diabetes within their patient population. And they recognized that the food that folks were getting at the food bank was exactly the food they should not eat if they have type 2 diabetes. So they organized, they found out what's the right kind of food. They negotiated contracts with the food bank and with local food distributors. And then they realized that people didn't know what to eat, how to cook. Some of them didn't even have a refrigerator or a hot plate. So they really surrounded these patients and they're making sure that they get the right food. So then she was talking about how it was such an effective program, they moved to another county. And I said, well, how did you do that? She said, well, we had to start all over. We had to negotiate new contracts with the food bank, et cetera. And at which point I said, well, the supply chain's involved in that contracting, right? And she just stopped and she said, no. But then, and I'd love to tell you more about this story, but then she turned to the supply chain and they jumped all over it. And I can share, if you want, some of the things that supply chain did there and that we're seeing replicated in other communities.
Yeah, I think that's giving an example that people can anchor on how they could get involved with programs like this that are truly transformational to the community. I think we'd love to hear that. Sure.
So you may know Juna Mora, who was the head of supply chain at the time. And what he did, he actually won an award from Gartner from this. But what they recognized was, well, what kind of food should we be sourcing? So it's kind of like the clinically integrated supply chain where you're talking about what devices we should buy. But in this case, what kind of food should we buy and who should we buy it from? So they did that kind of contracting. But then they were like, well, how much food should we order? And how do we take care of it? So it's really about demand planning, inventory management. Food expires. And, how do you make sure the cold chain and you're taking care of that food? Then they were like, how do we get the food to the patients? Because remember, if they don't have a refrigerator or a hot plate, they probably don't have a car. So how do we handle the logistics there? So they just really surrounded it with, the way I look at it is, it's really a supply and a demand matching issue. What do patients need? That would be the supply, and what is the demand of the patients? What do they need? And what are the supplies, the resources we have? And how do we make sure that we can connect them and get them to the right place?
I really like how you reframed it. It's what they need, not what they want. And a lot of times, supply and demand is based on want. But if you're really going to serve the community, it's got to be based on what they actually need, correct? Especially in this scenario.
Absolutely. And again, that comes back to that issue around health equity and the fact that, what a patient needs, a particular patient, just because they're different, will differ. But it's also, think about hospitals and healthcare systems, the needs of the community in the Phoenix area versus Omaha versus Boise versus Detroit, et cetera, is going to change. And it, to me, it starts with the community health needs assessment, and that's really too about when supply chain can really understand what's in that community health needs assessment and then start thinking about how can supply chain, not just the power of the purchasing dollar, but the power of the logistics as well, to make that match and make sure that, what Hayes needs or Justin needs or Garry needs or Karen needs or whomever, that we're doing that right match.
Karen, what you talked about, the different communities have different needs. But even I live in this great little area called Franklin, Tennessee. It's high income. It's a great place. But my wife's been delivering Meals on Wheels for 15 years. And the poverty of some of these people, they would not eat, literally could not or would not eat if it wasn't for Meals on Wheels. And then I know in the big cities, I think Johns Hopkins, they deliver meals. I think in certain, it's imperative that these people get food, or obviously they're going to end right back up in the hospital with all kinds of problems. And so it is a monster logistic issue to get the food, get what they need, where they need it, when they do it. But unfortunately, so many people need it.
Well, that comes right back to the economics again, because, the fact is, hospitals are struggling. Last year was probably their worst financial year on record. And how do we, with a few exceptions, some health systems are doing okay, but how do we make that business argument? And so a great example, this is from years ago when Bob Simpson was still at Lysar. They had a catering business and he was like, well, what else could we do with this? And then they started thinking about it. What if we delivered healthy meals to patients before they came into the hospital for a surgery so that we would make sure they are as healthy as possible? And then what if we delivered healthy meals for 3-4 weeks after they left? Will that improve readmissions or reduce readmissions? And,
there's got to be a white paper out there that supports that, Karen, all day long. It makes sense. It's logical sense.
So we already know bad data in means that we get unusable data. So bad food in means we get unusable nutrients with which to heal. It makes so much intuitive sense that there would be a strong correlation there.
Absolutely. And you've really seen a lot more of these programs, these food programs across the country. They've really proliferated. And I give Geisinger a lot of credit because they actually did a study. And so they captured the data and were able to share it. It's interesting, the Centers for Medicare and Medicaid Innovation, they are launching new programs where they're saying, you need to, for example, the ACO REACH model, you need to identify your underserved populations, identify what it is that they need, and then show how you're going to be doing that. And you're seeing Medicaid, for example, and allowing for up to 5% of the payments to go for some of these social determinants of health. So again, we just have to understand. And to your point, Garry, it makes perfect sense. But every once in a while, sometimes it seems to make perfect sense. Doesn't always make sense. We have to get the data. We have to do the studies, and then we have to replicate it across the country.
So you and I talked about this a little bit ahead of time, not in this great a detail, but just to frame up the conversation that we were going to have today. And I remember you somehow tied it back to the environment. And so I'm really curious. We're talking about economic drivers that are related to patient care. We're talking about, chronic illnesses. We're even talking about getting good food to promote, not just health, but health equity, right? Can you tie this to the environment for me? And we're likely going to have some resources available, a link to an article that you put together that we'll put in the show notes that everybody can check out. But what does this have to do with the environment? How does that tie in?
Oh, it's absolutely connected, and it comes back to that issue around chronic disease and around the cost of caring for chronic disease or the opportunity cost. If you think about it, if we've got so many people who are sick with multiple chronic diseases, that then we have to, then we don't have resources to take care of others. But so it comes down to chronic disease, health inequities, primary root cause of that, but the environment, climate change, other aspects are also increasing the prevalence of chronic disease. So if you think about it, and in many different ways, wildfires in the West, so Garry, you would certainly know this being in Boise. I mean, the amount of the impact that has on respiratory illness. I think, climate change, they say now, causes 6.5 million deaths globally because of respiratory disease. Or think about flooding in other parts of the country that increases mold. Well, that's an asthma trigger. That also increases a certain kind of chronic disease. And if you are poorer, you don't have the ability, as much of an ability to mitigate, because if we're having an extreme heat event, you may not have an air conditioner. Or if we're having extreme cold that's caused by climate change, you may not be able to stay warm because you can't afford the cost of heating. Or you always hear about these things about, the hurricanes coming, you must evacuate. Well, there's some people who don't evacuate simply because they have no place to go and they've got no means to get there. So it's about this root cause and how do we address this and how do we understand the different ramifications?
Yeah, we've had a lot of conversations around sustainability, but I don't think we've ever tied it into kind of like a big picture discussion around environmental aspects of sustainability before on any of these conversations. And I'm kind of remiss because we're already kind of at the end of our time. These conversations go so fast. I feel like, we could have several more of them, Karen. And I know you probably feel that you've only touched on the surface of a number of these themes, but let's give everybody that's listening just some immediate takeaways or things that they can be thinking about or doing and put into practice tomorrow to really address health equity, no matter what level they're at in a healthcare supply chain organization. Do you have a few tips or point people in the right direction?
Sure, absolutely. I think first of all is, when I'm speaking with CEOs, they're always going like, I'm having such financial challenges and you want me to think about equity and you want me to think about the environment. And I'm like, I don't have any more time. That's why it's so important to understand how it's connected, because if you're addressing both, you will be able to start addressing the impact of chronic disease on your institution. If you're in supply chain, this is a tremendous opportunity to, one, understand what are the strategic objectives of your organization. What are those community health needs assessment? And to think through as a supply chain team, where are all the different places that we could have an impact? Whether it's making sure that we are looking at the data on the efficacy of products to understand that these products, that there was actually a diverse N in the research, that we are also getting a plan to get the products to where they need to be, that we start thinking more than just, and this is the argument why I believe supply chain needs to really have responsibility for all non-labor spend. So it's not just about the knee replacements and the, cardiovascular devices and the sutures, et cetera, but it's about the food. It's about the housing. It's about even life skills training. But again, tie it to what is most important to your organization, your community. And in many cases, it's about economic development. So I would point people to the Healthcare Anchor Network. They have a tremendous amount of resources and case studies about supply chain being very active in that area.
Super good.
Excellent interview, Karen. Thank you so
Karen.
much.
She is an absolute icon, and she just brought it. She showed us how to do this.
Well, I'm a little passionate about the topic, but and
you're good at it.
Well, thank you. It's something I've been spending a lot of time thinking about for many years, particularly when I went back to grad school. I did a master's in the science of healthcare delivery, and I'm sure I made everybody crazy because there was a supply chain connection to absolutely everything we studied.
Absolutely.
Love it. Great job. You killed it.
Thank you, Karen. It was awesome.
Thank you.
Yeah.
Thank you.
That was Karen Conway, VP of Healthcare Value at GHX. And Hayes, this was an excellent conversation around health equity. And, sometimes we get really big picture on the show, and sometimes we get very granular. And I kind of feel like we bounced in between both of those, talking about, what's really happening from a holistic perspective in the communities. And I love Karen's examples, from Geisinger and some of the other examples that she gave, and the statistics as well that really back up like these chronic illnesses. And she also said, and this is kind of a closer for me, we've been talking about this for 30 years, and now we've kind of hit that point where economically we can't wait any longer. And she's right. We tried to be proactive about this in healthcare, thus some of the roles that I held, previously when I was still working as a clinician. That was all an attempt to be proactive. And while I think it made an impact, I don't think it's something that everybody got involved in. It was more like my program was addressing it. And what she's saying is we even pull in supply chain because that's what it's really going to take. Every facet of healthcare delivery has to get involved to make it really work on the scale that's required now.
She actually helped me see that differently. To your point, so many times it was siloed, and now she's saying it cannot be. We're to a point financially that we have to all come in and make a difference in our communities. And with these, with inequities, she just did a good job. She had all kinds of great examples. She had, like, as you said, she had percentages, she had numbers, and she's just really good at what she does. And it was a really good interview for me. I learned a lot.
Yeah, me too. Karen is definitely a dynamic and passionate individual. This was a great episode. I do want to remind everybody that if you have an episode that's made an impact on you, we want to hear about it. We'll even read your email here on air if you'd like us to. Just send an email to info@powersupplymedia.net. We'd love for you to share out our LinkedIn posts for the episodes or some of the other content that's going out. Continue to help build that awareness in that online community. We're also on Facebook. And then, of course, the best way to listen to this show is by downloading the Power Supply app for iPhone and Android. And if you're already listening, we're on those other platforms too. That's right. Apple, Amazon, Google Podcasts, iHeartRadio, Stitcher, Spotify, your favorite podcast application. We're there. Just search for Power Supply Media or Power Supply Podcast. And on behalf of Hayes, Gary, and myself, thanks for listening to this episode of Power Supply.